factor, the growth hormone stimulates the production of insulin growth factor from the liver, and that insulin growth factor will stimulate the growth of bone, cartilage, and soft tissue, plus all other metabolic processes, or other growth factors in the body. And what is the deficiency, not the deficiency, what is the clinical condition that occurs if there is excessive production of growth hormone from an adenoma? To understand, when we talk about primary, secondary, and tertiary, so for each of these hormones. So for instance, just an example, if we're talking about the ACTH, this adenocorticotropic hormone secreted from the anterior pituitary. The target organ is the adrenal gland, and the function is to stimulate the secretion of cortisol. Yes. And the excessive production of this will result in what condition? Yes. Or something like that. And this is the inhibition and the stimulation, because it is released from the pituitary, so there is releasing hormone that comes from the hypothalamus that stimulates. So if the hypothalamus is not working, then there is no stimulation, and then there will be no stimulation for the production of cortisol. But if there is excessive level of high level of cortisol, that will suppress the secretion of ACTH. So we talk about prolactin. I want you to know what is the most common adenoma of the pituitary. Prolactin secreting adenoma. So the most common adenoma of the pituitary is prolactin secreting adenoma, and then I expect you to know at least the major presentations of somebody with high prolactin level. And you know that prolactin that will affect the milk production in the breast. So patients with prolactin secreting adenoma, they will have milk production in the breast, even if they are not breastfeeding. And as I said, that is making table, their function, both male and female. Same way that it is here. And there are two hormones for the posterior pituitary. These are the ADH and the oxytocin. ADH was the target organ for ADH. They are collecting tubules in the kidney. And the idea is to retain water. So if there is no ADH, suppose that somebody has trauma to the brain, that damage to the posterior pituitary, what condition will result? What we call that condition? If there is deficiency of ADH, diabetes insipidus. Diabetes insipidus. That these patients that will have, polyuria, and they will have low osmolarity of the urine, high osmolarity of the serum, high level of sodium. So please, you need to know about the diabetes insipidus. So adenomas with prolactin, and we see that there's micro, macro, and the cutoff point for microadenoma should be less than 1 centimeter. Macroadenoma more than 1 centimeter. And when we mentioned about if the adenoma is secreting or not secreting, which will come first with the attention, the one with the secreting adenoma, because there will be clinical manifestation to the secretions, because they are hormones after all. So the non-secretory adenoma, which compared to the secretory adenoma, which will attain a large size before medical attention, that's non-secreting adenoma. So prolactinoma, so please. And for the board question about why do we have high prolactin if we don't have an adenoma secreting prolactin? What are other conditions that we can have high level of prolactin in the blood? Please be aware of this. So there is high prolactin level in the blood can be caused by medication. And remember what type of medication? The antipsychotic medications for depression. What's the mechanism for that? The mechanism for that is because these medications inhibit what? Dopamine. And dopamine is basically the inhibitor for prolactin. It is secreted from the hypothalamus, goes to the posterior pituitary and inhibit prolactin secretion. So whenever you have a medication that is inhibiting prolactin, dopamine, then there will be more release of prolactin. Similarly, there's another interesting point in patients with hypothyroidism. I want you to know, now I may give you a scenario about a patient diagnosed with hypothyroidism. What is the most likely effect of that on that pituitary? That will increase the secretion of prolactin. What's the mechanism? The mechanism is this. A patient with hypothyroidism, the thyroid stimulating hormone will be high or low? Be high. Thank you. So somebody with low level of thyroid hormones will send stimulation to the anterior pituitary to secrete more thyroid stimulating hormone. So this patient, hypothyroid, will have more secretion of thyroid stimulating hormone. The thyroid stimulating hormone comes from the anterior pituitary. Also, it will have another stimulatory function to the thyroid releasing hormone from the hypothalamus, and also it will have an effect of the thyroid releasing hormone to the prolactin releasing hormone from the anterior pituitary, and that is the thyroid releasing hormone. So in a patient with hypothyroidism, generally they have feedback mechanism stimulating the hypothalamus to increase its production of the thyroid releasing hormone. This thyroid releasing hormone has a stimulatory function to prolactin also. Again I said, somebody with hypothyroidism, meaning the thyroid gland is not making enough thyroid hormones. Now, this state, having low level of thyroid hormone, will stimulate the hypothalamus to secrete more of thyroid stimulating hormone, to stimulate the pituitary to secrete more of the thyroid stimulating hormone. The hypothalamus will release the thyroid releasing hormone that goes to the anterior pituitary to stimulate the thyroid stimulating hormone. Now this thyroid releasing hormone from the hypothalamus has also another function other than stimulating the thyroid stimulating hormone from the anterior pituitary, also stimulate the secretion of prolactin from the anterior pituitary. Is it clear? So this is another reason to have high level of prolactin in individuals who do not have an adenoma secreting prolactin. This brings us to another point which was very important. The level of prolactin. We mentioned in our lecture that if the level of prolactin is more than 200, it will be only associated with what? With an adenoma. But if it is less than 200, it can be because either of medication, which we mentioned, antipsychotic medication, or hypothyroidism. I hope this is clear. And this is the slide that emphasizes what I just told. And the symptoms that you need to know, the symptoms that are produced by any mass lesion in the brain that literally will cause vertigo, nausea, vomiting, increased intracranial pressure, all of that. But particularly, there is a very specific manifestation, clinical manifestation. We call it bitemporal hemorrhagia. Bitemporal hemorrhagia, and I explained that whenever there is a tumor arising from the pituitary gland, the tumor will press against the optic chiasm at this point. And this optic chiasm, that 50% of each optic nerve will go to the nasal part of the retina. The nasal part of the retina receive images from the temporal visual field, from the half of visual field, the outer half of the visual field on each side. We call that temporal side of the visual field. So that's here, this is the center. So that's the outer part of this sphere, that's the temporal. So the nerve supply to the nasal retina will be damaged because there is pressure by the tumor at this point. So the nasal part of the retina on each side will not receive images from the temporal part of the visual field. Therefore, these patients who have an adenoma arising from the pituitary gland, because it compresses on the optic chiasm here, and they will have this typical picture, meaning bitemporal hemanopsia. This is all the question. They just love to give you this type of picture. Show you bitemporal hemanopsia, meaning that these individuals will not be able to see the temporal part of the visual field. They only have tubular vision. Tubular vision. And then the different causes of hypopituitarism, meaning when the pituitary is not doing its job right, it is a reduced function, and it can be due to many causes. Because of damage, because of congenital, it is atrophy since birth, can be because somebody had another tumor compressing the pituitary. And please remember the most common tumor that results in this hypopituitarism, what's the name of that tumor? Craniopharyngioma. Craniopharyngioma. This is the tumor. As a matter of fact, if you are asked about the most common cause of hypopituitarism in children, is craniopharyngioma. Another point that I want you to be specifically aware of is this point, Sheehan syndrome. Sheehan syndrome. And this occurs, this is a condition that occurs in pregnant ladies at the time of childbirth when some of them lose a lot of blood. That can lead to ischemic necrosis of the pituitary gland. It is called Sheehan syndrome. Sheehan syndrome. So diabetes insipidus. Please remember diabetes insipidus. And what are the manifestations of diabetes insipidus, particularly in terms of the lab finding? The lab finding, I told you that these patients will have low sodium in the blood, high sodium in the blood, high osmolarity in the blood, low osmolarity in the urine. So this is so here the diabetes insipidus, these are the findings here. So please remember that about diabetes insipidus. On the other certain conditions that they are characterized by increased production of the ADH, antidiuretic hormone. So these conditions will absorb a lot of water. There will be hydration, dilution of the blood. So you can appreciate the difference between the two in this diagram.
What does the other one stand for?
Which one?
Diabetes insipidus, and what's the other SIADH?
Syndrome of inappropriate diuretic hormone. When the antidiuretic hormone is high in the blood, it can be because of medication. There are certain medications increase the level. Can be because of a trauma, so or a tumor producing ADH. So there are several causes for this. That's about the pituitary gland. Thyroid gland. Now I want you to understand the concept again, that the thyroid gland secretes these thyroid hormones, and these thyroid hormones are made from what? Thyroid hormones are made from iodine. Iodine. The stimulation for thyroid hormones comes from stimulation for the thyroid gland to secrete thyroid hormones come from where? From the dear pituitary, the thyroid stimulating hormone, right? And the pituitary to secrete the thyroid stimulating hormone has another stimulation coming from where? From the hypothalamus. So the hypothalamus will secrete thyroid releasing hormone. Thyroid releasing hormone will go to the anterior pituitary, stimulate the thyroid stimulating hormone. The thyroid stimulating hormone will go to the thyroid gland to stimulate the production of thyroid hormones. So that's what you see, the TSH coming from the pituitary, thyroid stimulating the releasing hormone coming from the hypothalamus. Therefore, with this understanding, now suppose we are talking about somebody having high level of thyroid hormone, high level of thyroid hormone in the blood. What do we call that? Hypo or hyperthyroidism? Hyperthyroidism. Somebody with high level of thyroid hormones in the blood, we call that hyperthyroidism. So high level of thyroid hormones in the blood will cause low level of thyroid stimulating hormone or high level of thyroid stimulating hormone? Low level. Therefore, if you are given in a clinical scenario, thyroid stimulating hormone is low, thyroid hormones are high, then we are talking about hyperthyroidism, right? And if the other way, that the thyroid hormones in the blood they are low, then the thyroid stimulating hormone will be high, and that is hypothyroidism. Okay? And then you have to know certain classic manifestations to differentiate between the two, because for instance, those with hyperthyroidism, this is when we come to that thyroid hormone direction functions, just to know what are the thyroid hormones. They are involved in metabolism. They are involved in metabolism. Wherever there is metabolic activity, they increase or stimulate that metabolic activity. So thyroid enlargement can be enlarged from inflammation, from goiter, from neoplasm, just for your understanding. Now when we talk about autoimmune disease of the thyroid gland, I want you to know two diseases. One disease is grave disease, that is hyperthyroidism. This is an autoimmune disease, meaning that there are antibodies in that individual that stimulate the receptors for the thyroid stimulating hormone to make more thyroid hormone. The other autoimmune disease is, what's the other autoimmune? Hashimoto. Hashimoto, that is hypothyroidism. There are antibodies that they block. The antibodies in Graves' disease, they stimulate the receptors. For Hashimoto, the antibodies, they block the receptors. So please be careful with the difference. That's why those antibodies, because they stimulate in case of Graves' disease, it results in hyperthyroidism. But because they block in case of Hashimoto disease, they result in hypothyroidism. The basic things that I want you to remember when you talk about hypothyroidism, just to understand it, that hypothyroidism, there is decreased metabolic rate. Decreased metabolic rate, meaning decreased energy. Decreased energy. So once anybody has decreased energy, will complain of fatigue, right? Cannot do work, complain of fatigue, tiredness, and there will be slow mentation. There's no enough energy for the brain process. Slow mentation. He thinks slowly, doesn't have the quick presence of mind, inability to concentrate, dry skin, and important, intolerance to heat or cold. Do you think somebody with low energy will have intolerance to heat or intolerance to cold? Cold. Yes. Intolerance to cold. The opposite of hyperthyroidism. They have a lot of energy. Intolerance to heat because they are warm inside. They are burning outside. So intolerance to heat for hyper. Hypo, intolerance to cold. And in a female, for this Hashimoto or hypothyroidism, irregular menstrual cycle. So when we say about primary causes of hypothyroidism, primary causes, it means in the thyroid. Secondary causes in the pituitary. Tertiary causes in the hypothalamus. I hope this is clear. So for Graves' disease, it is basically hyperthyroidism. A lot of energy production. A lot of energy production. And it runs in families. So when we say Graves' disease, it is an autoimmune disease. I want you to please remember that. So there will be the antibodies, there will be stimulatory antibodies. We stimulate the receptors for the thyroid stimulating hormone to increase the production of these hormones. So it is an autoimmune disease because of the presence of antibodies. There is also the cell mediated. So there are lymphocytes that also stimulate the tissues, and very characteristic sign, exophthalmos. Exophthalmos. This exophthalmos, that this is a sign of Graves' disease. Graves' disease. The explanation for that I told you, is autoimmune disease. It is mediated again by certain lymphocytes. These lymphocytes infiltrate the back of the eye. They go to the back of the eye, and there will be deposition of certain type of proteins, and these proteins are called glycosamine glycan or hyaluronic acid, along with retention of fluid, and that will push the eye forward. Will push the eye forward. That's why the eye will be bulging. That is the oxyphthalmos. So just remember this, not the other things. Just please remember hypo and hyperthyroidism and the Hashimoto and the Graves. The other things is okay. And when we talk about tumors, this list of the tumors, what I just want you to know, if you are at the most common cancer of the thyroid, it is the papillary carcinoma. Okay? This is one thing about the thyroid tumors that I want you to know. If you are asked about the most common cancer of the thyroid, it is papillary carcinoma. The other thing that I want you to know when it comes to tumors of the thyroid, if we are talking about the second cancer, follicular carcinoma, we have follicular carcinoma and we have follicular adenoma, benign tumor. Both can happen in the thyroid, follicular adenoma and follicular carcinoma. If you are asked the question, what is the major or the most diagnostic feature between follicular adenoma and follicular carcinoma, because histologically they look the same. How can you differentiate? Is when you see what? Metastasis. If that tumor, you see it in the capsule of the thyroid, or you see it in the neighboring lymph nodes, or in the blood, then you know it is follicular carcinoma. But if it is confined to the thyroid, it is follicular adenoma. So this is the second thing that I want you to know about thyroid tumors. Yes?
Can you repeat that once again, please?
To repeat it?
Yeah.
Yes. Particularly for the follicular carcinoma and the follicular adenoma, they look the same in terms of histology. Both they are large mass, nodule, what we call. And if you take a biopsy, you look at that, they look the same. Follicular carcinoma is the same like follicular adenoma. We cannot tell the difference, is this adenoma or this carcinoma? But it is important to tell. Why? Because treatment of carcinoma is totally different than treatment of a benign tumor. Treatment of carcinoma, you have to do surgery, you have to do radiation, chemotherapy, all that stuff. But if it is a benign tumor, you just remove it, or you may not even remove it if it is small size. So the only way to differentiate between the two, since you cannot differentiate on the basis of histology, you can only differentiate if you see metastasis of the tumor. And the metastasis will be either in the capsule or to the neighboring structures. So, if I give you a scenario, for instance, that the patient was found to have a follicular tumor of the thyroid. And the surgeon, he wanted to reach a diagnosis. The only way to reach a diagnosis is to see the presence of. And if I give you the list of things, then to see evidence of metastasis. When we talk about follicular adenoma or follicular carcinoma, please keep that in mind. Yes, of course. So adenoma is benign too. So that's what they are expected to know about these tumors. And this is the picture. This is the picture. You see that circle? So here is the thyroid, and this is the capsule. You cannot read that. This is the capsule. This is the capsule. And if you see the tumor is within the capsule and this large image, then that is cancer. Is it clear? Clear. What's that? See it what? The pointer? You are right. So this is the tumor, right? Within the thyroid. This is the capsule. But the tumor is going into the capsule. So this is the large image of that, so you can appreciate that this is present here. This is the capsule, it is within the capsule. But if it is all contained only here, and the capsule is intact, then it is adenoma. Another thing, the third thing that I want you to know about thyroid cancers is about this medullary thyroid carcinoma. Medullary thyroid carcinoma, that this tumor, it also secretes calcitonin. Just remember, this tumor secretes calcitonin. Calcitonin lowers calcium level in the blood. And another thing about this medullary thyroid carcinoma, it has amyloid. It has amyloid. So, this is the function of calcitonin, lowers calcium in the blood, and it has amyloid. And to identify the presence of amyloid, we have to use a special stain. The special stain for amyloid is congobrate. Please remember that. That can be a board question. So this is the special stain, congobrate for amyloid. And this is also, it has, when you look at the histology slide with a lens called polarizing lens, you will see birefringence. And the typical name they give, apple green birefringence. So this is for amyloid. And this amyloid is associated with medullary thyroid carcinoma. So please remember medullary thyroid carcinoma. Another thing about medullary thyroid carcinoma, do you know what? It is association with multiple endocrine neoplasia, MEN syndrome. So that when we talk about MEN syndrome, I will refer to that. So we like to have 5